Hello, esteemed members of the Egyptian Orthopaedic Association and all attendees. My name is Kapil Sugand. I'm a locum consultant in peripheral nerve surgery at the Royal National Orthopaedic Hospital in the UK and an honorary research fellow and senior teacher at Imperial College London. I've been given the privilege of presenting at the Congress this year on the top 10 technological advances in trauma and orthopaedic surgery. We are currently dealing with some international and major challenges in our craft. There are reduced training opportunities in the UK and mainland Europe. This has reduced up to 80% since the introduction of the European Working Time Directive, and the COVID-19 pandemic has also had a direct impact on patient care and waiting lists as well. Although, on the other hand, there are increased number of operations in trauma and orthopedics, whereas disease burden is increasing and is ranked higher and higher according to the World Health Organization. There are also an increased prevalence of medical, legal, and lawsuits requiring fiscal compensations due to iatrogenic errors, and a huge brain drain that we're facing on our side of the world. So let's focus a bit more on the educational side. What does it take for the future generation of surgeons to be trained safely? Well, there are many qualities of a surgeon that come both down to technical and non-technical skills. And that's something that we have generationally learned on the job from our trainers, from our mistakes. But is there anything that technology can do to improve the learning experience and at the same time protect patient safety as a top priority? We'll be looking first of all into the role of virtual reality and surgical skills. Now, medical simulation has become mandatory around the world in order to improve surgical education, and all of this is in order to maintain patient safety without compromising it. There are many countries, including the UK and Scandinavia, that have now incorporated simulation as part of their formal curriculum. Back in the day, it was said that you see one, do one, and teach one. Now we can see one, do many, and teach many more with the help of simulation. So what is simulation? It is a recreation of a clinical exercise in an immersive, realistic, and interactive controlled environment to learn, develop, and master technical and non-technical skills without compromising patient safety. And what makes a virtual reality simulator valid is part of my research, which looks into, does it look real? Are the operative steps realistic? Can the virtual reality simulator differentiate between levels of skills and expertise, such as a medical student versus a consultant? And the gold standard and the holy grail is being able to learn on a simulator and bring those skill set to the operating theatre on a patient, so that you practice the operation many times before you perform it for the first time on a patient like we've done historically. These are some of the early virtual reality simulators. On the left you have the dynamic hip screw simulator, and on the right you have the knee arthroscopy simulator. As we can see here, we have a dynamic hip screw simulator where a guide wire is put into the left hip fracture. Using both an AP and lateral view, you can then measure off a depth gauge and put in the lag screw as well as the plate. The benefit of doing this procedure is also that there is a haptic feedback using the phantom stylus pen, so you can actually feel pushing against the bone and you can feel the feedback of drilling into the proximal femur. The simulator measures 17 real-time performance metrics, including the only clinically validated metric from Baumgartner, which is a tip apex distance. It gives a universal score depending on how well you've done in all of the 17 metrics. And the idea is that with persistent practice, one will be able to improve their skill set before making any potential mistakes on a patient and learning the hard way like we all have, and done so historically. I published this with my research team in London on what it took to be able to differentiate levels of trainees and experts using this DHS simulator. So we had novices who were early postgraduate doctors within 4 years. We had intermediates who were registrars, fellows, and residents. And then we had the experts and the attending, all having one go at the simulator to see if you could tell the difference between level of expertise. What we found was very interesting. Although the simulator was able to differentiate between novices, intermediates, and experts, some of the results, such as the number of attempts of putting in the guide wire, were certainly more so in the intermediates than they were in experts and novices, because intermediates compared to the novices were more familiar with the tip apex distance and the clinical significance of that. So they made sure that they would reach the correct tip apex distance, even if it took more attempts of putting in the guide wire. The fluoroscopic time was much higher in novices because, again, they were new to the operation and wanted to make sure that they were putting the guide wire in the right position as well as the lag screw. You'd be surprised to see that the tip apex distance and the probability of cutout was actually the best in the intermediates, i.e. the residents and the registrars, just because in the UK, where we conducted this trial, the residents and the registrars tend to run the trauma lists, and so they tend to have more experience with the dynamic hip screw fixations, which is required for them to demonstrate their competency to become a consultant and attending one day, and leaving the experts or the consultants with the more difficult DHS cases, and hence it was a comparable result. And all in all, because of the increased exposure and practice on DHS surgery, relatively speaking, to all three groups, the intermediates outperformed everyone else. We then did a training effect on medical students to see how many, what would be the effect of the scores if medical students had multiple attempts at doing the DHS operation. And as we can see, that by the 10th attempt, all of the metrics had been improved in the people who had persistent practice over 2 weeks, compared to the control group who only had one attempt in week 1 and one attempt in week 2, and they didn't really change much from the baseline of the first attempt from everybody else. So this goes to show the simulation is not meant to be only done once. It is a persistent and rehearsed practice that will improve your skill set in order to avoid something we call a skills decay. We then compared the number of times the medical students needed to do the DHS operation in order to reach the same level of competency as the consultants who had only had one attempt. We found that by anywhere between the first to 7th attempt, depending on which metric, that the medical students were reaching the same level of consistency and competency as the consultant's first time attempt. It's also important to mention that whenever you ask somebody to have a go on a simulator, there's always going to be a learning curve on using the hardware as opposed to being able to fully engage with the clinical exercise in front of you. So it is slightly unfair to compare it to the consultant first time attempt, because on the first time, even the consultants are familiarizing themselves with the machinery, and the hardware, not just the software and the clinical exercise. But it goes to show that with persistent practice, using the same simulator, even novices, including medical students, are able to show comparable results to expert consultant orthopedic surgeons. And this is for DHS surgery only. We also have arthroscopy, where we've done many shows for both healthcare professionals, physiotherapists, and the public on how we want to train future generation of orthopedic surgeons using virtual reality, so that the trainees are confident in what they are looking for and what they are doing long before they enter the operating theatre. This is a probing exam, a 10-point exercise where the participant will familiarize themselves with the localized and regional anatomy, but also be able to practice their hand-eye coordination and spatial awareness, as well as triangulation, in order to find the important points that we all look for during the knee arthroscopy. As we know, knee arthroscopy is the commonest orthopedic operation in the world, and it is important that no matter what speciality you eventually end up in, including peripheral nerve surgery in my case, if you want to be an orthopedic surgeon, it's important that you are able to demonstrate competencies in order to become a consultant, including arthroscopic work. Other methods of applying simulation include in operative steps in surgical decision making. This could be something similar to this module that we created in association with Touch Surgery, which has been bought by Medtronics. This is an app that's freely available, in which anybody who downloads it is able to go through the surgical steps of a procedure, in this case a femoral intramedullary antegrade nailing, and be able to participate using their digits to make the incision and be able to guide the awl, the guide wire, and the nail eventually, whilst answering questions step by step in order to familiarize themselves with the operation technique, so that they are prepared and know what to look out for without any nasty surprises before they go into theatre and conduct this on a patient. Obviously, we know that every fracture configuration is different and they come in varying degrees of complexity. What you don't want to do is to put too much cognitive load and distraction on what the next steps ought to be, because the fractures that we deal with can be rather complicated. And so we should be very comfortable with the techniques and the operative steps beforehand, so that we can manage any unexpected and unpredictable problems that we face during the operation. This module comes into 4 different steps and has been viewed and used by around 100,000 people all over the world. Again, we ran some research on looking at validation using the 4 modules for femoral nailing, and we found that, again, this application was able to differentiate between novices and experts with statistical significance. Again, we did a training effect using medical students to prove that with sustained practice, the scores for the questionnaires, which to do with the knowledge base of the operation and the economy of movements and knowing exactly where to place where what, had also improved with sustained practice. Dynamic holography is something that we had introduced, and we were one of the first research groups to do so, so much so that we were covered by international media, including BBC News, as well as Wired magazine. And what we were trying to do was to bring holograms into the lecture theatre for the very first time. This was to revolutionize didactic lecturing using PowerPoint presentations which are static and convert them to dynamic, augmented reality and holography that makes things more immersive and interactive. So to improve the educational impact and memory retention for the participants. And we had done this throughout many specialities, including trauma and orthopedic surgery. As you can see here, we've done some on renal physiology as well. The need for this was because there was research to suggest that students and participants in any lecture tend to only maintain 10 to 15 minutes of attention in a lecture before they are unable to absorb any more information. Now, with the introduction of HoloLens and the metaverse using VR goggles, you can now see the entire operation from start to end in all specialities, as well as interact with skeletal models in this case, as you see on the screen, in order to appreciate any anatomical variations or any difficulties that you think you'll encounter as a surgeon before you go into theatre. This will give you more of a preparation and mental capacity before conducting a difficult operation. Another thing that virtual reality has helped us to do is to improve our decision making. So we created a virtual patient that was a road traffic accident and a polytrauma that came into your major trauma center now in the resus bay. There was some baseline information given to the participant on ATLS principles and both 4 guidelines on how to manage an open limb fracture. In this case, this was the right tibia. And the idea was to ask 247 multiple choice questions on how to manage this patient from the moment they come in with an ambulance into the resus bay to the point where you're going to put the right sized venflon for fluid resuscitation and maybe even transfusion, why you would do what you would do and what test you would take and why so. And after every question and after every answer would come an explanation slide with the evidence-based medicine as to why you would do what you are doing. In case any questions were incorrect, the participant had another chance to go through the exercise until they got it right. This was until the very last moment where the patient would be discharged after having an operation and post-operative complications, including a DVT and a PE, as well as compartment syndrome. Once again, some preliminary data here suggests that when comparing the validity of interns versus residents and fellows, that the fellows did the best in terms of the scores they received during this exercise, and the people who were already familiar with ATLS and both guidelines had improved scores than those who were not familiarized with either of those guidelines. So this virtual reality world gives people a chance to apply the guidelines they read into a clinical scenario before having to manage this in actuality. There is also a need for simulating procedural skills and being familiar with new equipment. What we had done here is conduct distributed interactive simulation where we inflated an igloo theater. We set up a sawbone with a soft tissue envelope in order to get our trainees familiar with new equipment that was being introduced for femoral nailing by a new company. We had a scrub nurse who was actually the orthopedic rep from the company. We had an anaesthetist and the trainee you see on the right side. So we were trying to emulate an actual theatre. We were using real equipment, and there was no need to use any fluoroscopy intraoperatively, since we were using electromagnetic technology in order to achieve the distal locking phase of the femoral nail. So the trainees were still getting the most of the educational opportunity without the need for x-rays. And as we know, sometimes the distal locking at the end of the operation can sometimes be the most challenging part of the procedure. Other things that have now come into the market are orthopedic exoskeletons, where we can now mold these plinths, which are not only thermoplastic but also carbon fiber and lightweight but very durable, that are custom made only for patients, and there has been research on this published as well. This would take away the need for plaster of Paris or any casting, which has its own complications. Exoskeletons have also been used in being able to counteract the crouching gait for a patient with cerebral palsy in order to improve their functionality. We see that this piece of equipment is rather bulky and may not be suitable for patients that don't have the strength to be able to carry all of this. But remember, we're in the first phases of all this, and this will improve as time goes by. Attached to with wires to other orthoses around the limbs, the handheld machine, as well as an emergency stop. What's even more impressive is that patients with spinal cord injuries that have lost the ability to ambulate are now able to purchase very expensive machinery that will allow them to do home-based functional ambulation, and will also improve, due to the locomotor effect of being able to walk after spinal cord injury, other things such as spasticity, trunk control and tone, bowel bladder function, mental health, and obviously quality of life. We're also understanding that one size doesn't fit all, and that includes implants that we put into our patients. And sometimes, because of the anatomical variation of patients, sometimes the scans don't do justice for us to be able to predict, expect, and counteract any problems or unpredictable variations in anatomy that could jeopardize the outcomes of the operation and increase the risk of perioperative complications for the patients. Over here, we see 3D printed models of patients, both the skeletal anatomy as well as the vascular anatomy, in case it's a difficult case after, let's say, a pelvic fracture, acetabular fracture, that needs to be addressed with either arthroplasty or fracture fixation. On the right-hand side, we see that this is a custom-made acetabular cup and mesh that has been printed for the morphology for this particular patient, and it will not fit anybody else's acetabulum. Obviously, the downfall of this is that this is rather expensive, and not everybody has the accessibility to large or small 3D printers. But some of these implants that we use in our trust can exceed anywhere between £20,000 to £50,000. However, it does give you a greater appreciation preoperatively to understand what the challenges will be once you open the patient up. This could potentially improve clinical outcomes, including the longevity and the lifespan of the implants, as well as reduce the risk of surgical complications. The printing and patient-specific implants are not just to put into the patient, but they can also be used to create specific personalized jigs in order to help with osteotomies and arthroplasty using CT 3D reconstructions as a template. There's a huge drive to incorporate robotic and computer-assisted orthopedic surgery that we call chaos. And there's also a use of AI in arthroplasty and robotics where there is differing evidence regarding a lower revision rate, lower risk of manipulation under anesthesia, decreased systemic complications, lower opioid use due to lower postoperative pain, and faster return to range of movement and baseline function in those active. It's important to understand that, again, it is vital that robotic surgery doesn't replace conventional surgery, and every arthroplasty surgeon ought to be able to comfortably do a hip or knee replacement manually, because the machines are never foolproof. There is a learning curve for the surgeon to get used to the machinery, and in case of a power cut, if the machine fails, you still have to be able to convert to a conventional operation and finish off the operation. This is also very consultant-led and is not usually for trainees to learn on until they are competent and can demonstrate that to their trainers that they're able to do a joint replacement manually and conventionally. There's also more and more machinery in pedicle screw insertions for spine surgery too. Orthopedic wearables is an exciting avenue to venture into nowadays, because we can have both wearables, and I'm sure some of us are already wearing them right now. That could be due to the watches that we wear that are connected to our phones that measure the number of steps and our heart rate and other metrics like that. But for orthopedic wearables, they can both have internal and external options. You can have microchipped implants that can measure metrics, and you can be wearing electrodes on the outside to measure those too. You could be measuring step count, cadence, stride, walking speed and velocity, tibial shock on joint loading to predict the longevity and the lifespan of your implants, to figure out the wear patterns as well, and the need for revision surgery, as well as recovery kinetics post-operatively after an arthroplasty, with clinical and patient-related outcome measures. Can you imagine that the data that we would acquire from the measurables on our patients would then be able to give us a better quality of data set and improve our research capabilities to offer the patient the best implant with the best longevity for the demands of the patient. All of that information can also be integrated into artificial intelligence, which is now becoming the buzzword everywhere and a disruptor in all industries, including in orthopedics, where there is applications of artificial intelligence that has been published here, anywhere from arthroplasty to spine, orthopedic oncology, trauma, and sports medicine. We're able to use artificial intelligence in order to predict when there would be a failure of an implant, even failure of soft tissue and cause of injuries, and being able to predict the chances of oncological disease as well as prognosis depending on our intervention. It could even be as simple as being able to tell a patient from baseline down the line when you see them again in clinic on the evolution of their degenerative joint disease and the need for arthroplasty. Using templating software and artificial intelligence, rather than us doing it, the machine is able to, with the help of machine learning and deep learning, tell you exactly where to make those cuts for your hip replacements and which sized implants to put in. This again has been published. What will help you is to feed many of these pre-operative and post-operative x-rays of your existing patient data of their x-rays into an artificial intelligence software so that you're teaching it, it can learn, and then it will become more autonomous and be able to tell you where the right cuts ought to be made for future cases. This can lead to highly accurate positioning of the components that would help with clinical outcomes as well as patient-related outcomes. So what about the AI in diagnostics, which is becoming more and more popular, especially in orthopedic surgery? Here, for example, we have a 3-year-old boy who complains of pain returning after a park, but on clinical examination there wasn't much there. I'll give you a couple of seconds, but can you spot the abnormality here? If you did or if you didn't, the artificial intelligence software certainly did by demonstrating where the fracture was. And it can also be used in bone metrics in order to accurately measure the angles that we so heavily rely on in orthopedics to restore function for feet, legs, pelvis, hips, and spine. And it will also help you as a surgeon to decide where to make your corrective osteotomies in multiple planes and where you'd like to put the implants in at what angle. I'd like to thank all of you for attending my virtual presentation. I'm sorry I couldn't be there in person to deliver this, but I will be there later in the week to discuss my other lectures in peripheral nerve surgery. In the meantime, thank you very much for the opportunity, and I look forward to meeting all of you and answering any questions in person. Thank you very much. Enjoy the Congress.